Good afternoon, everybody. Thank you for coming and attending this workshop that's been organized by MC Pharma. My name is Denver Wickham and I'm the Head of Operations for MC Pharma, the pharmaceutical company. You all will know us as the company that has provided Garacol, which is the implant, gentamicin containing implant that you guys use for prevention of surgical site infections. But at the same time, we've got the introduction of a new product in South Africa, which is a new clinical innovation which we'd like to introduce you to. So I've got on the line from Italy, we've got Professor Randelli, which is an orthopedic surgeon, and he specialized in hip and trauma surgery. And he's now currently at the Gaetano Pini CTO Orthopaedic Institute at the University of Milan. He graduated from medicine at the University of Milan in 1996 and completed an AO in trauma fellowship and in trauma at the trauma at the hospital for surgery and special surgery in New York in 1999. He passed the Italian Orthopaedic Trauma Board Examination, cum laude in 2001. Since 2010, he's been a contract professor at the Milan Orthopaedic and Traumatology Residency Program. Dr. Randelli is a consultant editor of the Journal of Orthopedics and Traumatology, chair of the ESSKA Hip Arthroscopy Committee, and involved in the board of different scientific societies. He's the author of numerous original research articles, H-Index 14, and the review of the Lancet and external reviewer. Also part of the scientific report, which is a Nature journal, KSSTA, that is the Knee Surgery Sports Traumatology Arthroscopy journal, and also the JHPS, which is Journal of Hip and Preservation Surgery. So thanks, Prof Randelli, for gracing us with your presence and being present here. We know it's a difficult time, and we know we probably want you here during real time, but it's a real privilege for us to have you here to explain to us about the new Guna medical devices in South Africa. Thank you.
Thank you, Denver, for the kind presentation. Thank you to everybody. And I will talk today about something that I've struggled with for a long time. And the problem is the Greater Trochanter Pain Syndrome. First of all, I would like to introduce myself. I'll try to, okay. I'm working now at the Gaetano Pini Orthopaedic Institute, which was built in 1874. It's a very famous orthopedic facilities in the center of Milan, just 500 meters from our Duomo, our main church. It's famous also because Galeazzi was the chief of this hospital many, many years ago. So once I was thinking about how bad it is to try to treat recalcitrant Greater Trochanter Pain Syndrome, with a pathology that is very frequent for a hip surgeon as I am. I do only hip and trauma in my life. And I was thinking about this lady that has lateral hip pain since 6 months, and nothing was working with her. You see, she had only just a mild tendinopathy and bursitis. So the problem, let's talk about the peritrochanteric space first. It's a crowded space, and it's a tight space where you have a fascia lata from one side and bone, the greater trochanter, for the other side. And in the middle, you can find tendons, small nerves, and bursas, more than one bursas. So the tightened structure is the iliotibial band, was made by the fascia lata and tightened by the gluteus maximus posteriorly and by the tensor anteriorly. So let me take you inside the peritrochanteric space. I'm just incising the fascia. I immediately find the bursa, and now I'm removing the bursa, and you will see just below the bursa the gluteus minimus, and now I'm holding the gluteus minimus with my finger, and there is the vastus lateralis, and you can see a very tight space with tendons covered by the band, the iliotibial band. And this is an endoscopic view of the same space. You see the muscle belly of the gluteus medius, and you see now the trochanter that is moving inwards and outwards with internal and external rotation. So it's one space that every hip surgeon knows very well because we always pass through the space. So the pathologies that affect the space are the trochanteric bursitis, the external snapping hip syndrome, and also the gluteal tendon lesion. This is the main pathology I will talk to you about today. So the trochanteric bursitis is the thickening of an inflammation of the bursa and is well known by many years. But you should know two things about the bursitis, the bursa, the trochanteric bursa. The first one is that it mimics other pathologies, and we will see which pathology, and often is not a pathology itself, is just a victim of a pathology. Trochanteric bursitis often mimics radiculitis. Why? Because of the inferior gluteal nerve. It's a small sensitive nerve that coming up to the central nervous system pass through the fifth lumbar and the first sacral road. It means that it creates a sciatic pain. And I've known many patients that have been operated for herniated disc disease, and they also or only have a problem of the peritrochanteric space. But another problem is that the bursitis itself is not the pathology. I just told you the pathology is the tendinopathy that is just near below the bursa. So since 1985, we are talking about the Greater Trochanter Pain Syndrome, and we include in this syndrome a medius or minimus gluteus pathology, and then the reaction of the bursa as a bursitis. So how the bursa got inflamed? There is a genesis that comes from out in, and a genesis that comes from in out. Let's talk about first about the genesis from outside. You have a thickened iliotibial band that is tightened posteriorly from the gluteus maximus, and this band snaps over the greater trochanter, making inflammation. The pathology is not the snap, it's the pain related with the snap. And I told you this is just one of the cases of the Greater Trochanter Pain Syndrome. You also have other conditions. Since many years, we have been talking also about the rotator cuff tear of the hip. As it happened in the shoulder, you may have a tight structure that in the hip is the fascia lata. You have bone tuberosity, you have tendons, and you have a bursa. So it's quite similar, the mechanism that will create the damage. But we know also that in the hip, we have a strict correlation with the femoral acetabular impingement. That is the first cause of hip arthritis. So we have a mix-up of pathology that may have concomitant problems at the trochanteric tendons. And this is a classical case. This is a 40-year-old female runner with bilateral trochanteric pain 6 months with an external snap at the left hip. So you may focus that the problem is only on the trochanter, but was not. You see an arthroscopic view of this hip, and you see that she has a labral tear, she has attachment of the cartilage, what we call the wave sign. So the problem was inside and outside. So we did labral refixation after a small retrimming of the acetabular anterior acetabular wall, and then we did osteoplasty, removing bone from the proximal femur, and then we also released the fascia. Which are the clinical signs of the Greater Trochanter Pain Syndrome? The first one, the main one, is the lateral hip pain. But lateral hip pain is very, very common. If you are a hip surgeon and you touch the trochanter, half of your patient will have pain during the maneuver. And there are a lot of pathologies that may have lateral hip pain. I want to tell you about the story of Giacomo, who was a 16-year-old boy, was a sports boy, and he started to have lateral hip pain. So he was sent to a physiotherapist, and he did physiotherapy, taker, laser, a lot of things, but he still had pain. So he went to the general doctor that asked for an ultrasound. The ultrasound was negative, so he was back to the physiotherapist and did other 3-4 months of physiotherapy. But nothing happened. The pain was still there. The lateral hip pain, the only symptom that this young guy had. So after 6 months, he went to an orthopedic, and the orthopedic asked for an X-ray. And the X-ray showed something wrong at the trochanter. Something very wrong was a chondroblastoma, with a locally aggressive pathology in the worst place, because that is the place where tendons attach to bone. And if you don't have a greater trochanter, you will limp for the rest of your life. Another lateral hip pain source is incredibly the avascular necrosis of the hip. People will have pain in the lateral side of the hip at the beginning of the avascular necrosis. It happens very often. And this is the case. You will see nothing at the trochanter, but you will see the necrosis at the femoral head. So in patients with the Greater Trochanter Pain Syndrome, the main issue is pain. You touch the area around the trochanter, and interestingly, the pain is often more distal than the trochanter, because there, distal, the bursa is as a kind of ridge that tightens the vastus lateralis. Sometimes you have the snap, as in this lady, and you see that when she has the snap, she has pain, a kind of sussultation. And then you check for the tightening of the iliotibial band. This is called the Ober test. But you also want to check the strength of the medius and minimus, okay, from both sides. As this was an athlete years before, a soccer player, goalkeeper, and she has a reduced strength on the left side. This may arrive even to the Trendelenburg, you know, the limping. Another thing you should check every time you have a lateral pain is an eventual leg discrepancy, because if you have a longer lower limb, you will have the fascia lata that will tight more against the trochanter and create the problem. How do we diagnose it? You see, we do the clinical examination, that's very, very important, the X-rays, ultrasounds, but the main definitive diagnosis is made by an MRI. You may see sometimes some ossification at the insertion of the tendons, but when you see inflammation at the level of the insertion of the gluteal tendon, you know the pathology is there. So GTPS mainly affect two kinds of patients, young and middle-aged, mainly women, young middle-aged with a snapping hip with a tendon lesion, or older ladies, and that is a degenerative disease of the tendons. So you can see this was a young lady, about 30 years old, with a tear of the tendon, but the tissue is not so bad. But then you have this, an older ladies with a severe degeneration of all the tendons, as you can see in this endoscopic view. And then we have a third kind of patient, that is the Greater Trochanter Pain Syndrome after a total hip replacement. Why it happens? Different reasons. If you do a lateral approach, sometimes it's because of the approach, because the approach may weaken the muscles and may create a scar at that level. But it happens also with the posterolateral approach. And incredibly, it happens also with the direct anterior approach, but with a different mechanisms. This is a very unlucky lady because she has some kind of Greater Trochanter Pain Syndrome on the right, where she had a lateral approach, but also on the left, where she had an anterior approach, but with a widening of the offset. If you widen the offset, you have a trochanter that will push laterally, and you will create a kind of lateral impingement, and so the symptoms. You can see with a CT scan reconstruction that the offset of the femur is widened. And this is another lady also with a widened offset that not only and a GTPS, but also a psoas problem, because if you lateralize the lesser trochanter with the femur, the psoas will not work properly and may start to provoke pain to the patient. So this psoas problem is not only a cup malposition in total hip replacement, can be also an augmented offset. So which is the treatment? We always start with conservative treatment in these cases, weight loss, activity modification, physiotherapy, trying to lengthening the iliotibial band. We try to compensate if there are leg discrepancy, and we also use shock wave therapy, and we do injection. So if you check the literature, you will see many different kinds of possible injection with only the dry needling, or steroids mainly, or PRP, or even autologous tenocyte injection. So when you have so many different kinds of therapy, it means that you don't have the right one or the best one. What about steroid injection? They give you good result, temporary, but not always in this pathology. And also, if you do it freehand without an ultrasound, there are papers that show you that the chance to get in the bursa, that is not so far, is there, but the chance are not 100%, it's less. And if you want to get to the tendon, for example, it's even more difficult. So at the end, but really at the end, in few cases, we go to a surgery, endoscopy, or open. We can do a lot of things today with an endoscopy. We do the prosectomy, the release of the iliotibial band. We also do some tendon repair. We just reserve to open surgery today the biggest tears of the gluteal tendons, or if we have to do an allograft augmentation of the tendons, or if we need to do a gluteal transfer. We will see. At the beginning of the 2000, I was used to release the iliotibial band just with a small incision and then a cruciate cut, as you can see in these images, but not today. Because today then comes the arthroscopy, and the endoscopy in this case, and we do release the fascia in 3 different ways: from above the fascia, from below the fascia, and doing a release of the femoral insertion of the gluteus maximus. I will show it in a few minutes. This is the release from above the fascia. So you start creating a space lateral to the fascia lata, detaching from the fascia lata the subcutaneous tissue. In fact, when you go see, you see the lipid, you see the, and you don't see almost anything. You have to create a space because there is no space in nature. You create a space until you see the white shiny tissue of the fascia lata, and you can also move the hip, watching at the trochanter as a wave below the fascia. And then you cut the fascia, you make a kind of cross, and then you create a diamond shape because you shave the corner of the cross. Okay. And sometimes you arrive to also, then this is the bursectomy at the end. Sometimes you arrive also to cut the anterior portion of the gluteus maximus. This is the endoscopy from below the fascia. It means that you enter with the camera between the fascia lata and the trochanter. You see you have seen the trochanter moving, and now you see that you can cut from inside, outside the fascia lata. It's very funny to see how it releases when you cut it. Okay, and this is the fat tissue that you are seeing from inside. And this part is the release of the anterior margin of the gluteus maximus, which is very tight in these cases. But then came Polesello, who is an Italian guy who is working in Rio de Janeiro. His Italian origins is not Italian at all. And he discovered that you can release the fascia lata from the trochanter without touching the fascia lata itself. You just need to cut and release the insertion of the gluteus maximus at the linear aspect of the femur, and this release will create space between the iliotibial band and the trochanter, and the snap, if there is snap is there, will disappear. You see the yellow line is where we cut the tendon, and this is an image. We are inside the bursa now, between the greater trochanter and the fascia lata. We create a space, and you know, when the bursa is very inflamed and big, it's not so easy. You have to work for a while. And when you see the vastus lateralis, that is, you can see the line, the horizontal line as the vastus lateralis, you see the trochanter, you go down below the vastus lateralis, and you see the tendon. This is the femoral insertion of the gluteus maximus, and you cut it. You make a transversal cut, and you see that the tendon will release and a gap will appear. This means that trochanter now has more space to move away from the fascia. You see we are cutting the tendon, and meanwhile we are cutting the tendon, a gap is visible as it is now. So you see the tendon before and then after the release. Do we repair the tendon endoscopically? Yes, we do. It's not so easy. Sometimes we have to pass through the gluteus medius tendons to get to the minimus tendon to have to be reattached. And this is a case of a suture anchor in the greater trochanter, a suture passer through the tendon of the medius gluteus. We use the shuttle technique, and we make the knots. We use rarely one, mostly 2 or 3 anchors, because you know there is a wide tendons of the gluteus medius. But sometimes we have a huge lesion of the gluteal tendon, as in this case, and we do prefer to do it with an open fashion, because sometimes we have to transfer the part of the gluteus maximus over the trochanter. You see, this is the remaining of the medius and minimum gluteal tendon, and even if I pull against the trochanter, it's very difficult to get in the right place, and if you suture too tight, they will lose in a second. You can use some kind of augmentation, but then we protect it with what you see here below, with a transfer of the gluteus maximus. So you have seen how many things we do to try to treat this pathology, because it's a difficult pathology to be treated. And I was thinking about what to do to this lady, and then a pharmacist rep entered my office with a new fantastic, she said, medical device for trochanteric pathology. I wasn't so sure. And so I asked her to let me see the literature of the use of this device in a greater trochanter pain syndrome. And if I would be convinced, I will use it for sure, because it's a problem for me, this pathology. And she said, oh, we don't have it. So let me see your basic study in vitro with tenocyte. How do they react, the tenocyte, to your device? Those are the cells of the tendon. They create collagen. They create healing of the tendon. Oh, they are not. This is how a study was born. So we would try to set up a study using this swine-derived collagen on cultured human tenocyte, focusing on collagen turnover pathways. That means tendon biology and especially tendon healing. So I passed through an ethical committee, and I asked 8 of my patients the permission to take a small piece of his gluteus minimus tendon through an anterior approach during a total hip replacement. And you can see in this picture here is a small piece of the gluteus minimal tendon. I'm coming from anterior to do a hip replacement, and then that very small piece of tendon was the cells were isolated from that piece of tendon and then cultured alone or with this guna MAD tissue, this collagen. And then we did, with the help of Professoressa Galliano, who's a scientist in our university, we did a lot of tests to check what cells, what tenocytes do in the presence of this collagen. And first we see, and I was personally very surprised, that there was a very nice cell proliferation in the presence of the collagen. Then we see that collagen was augmented in our study group. And then we see that the stability of the collagen was good because the LH2B mRNA was stable. And the degradation of the collagen was unaffected. And then we discovered why the degradation of the collagen was unaffected, because the inhibitor of the molecules that degraded the collagen usually was augmented. So we discovered why the degradation was not affected. We try also to check if there was a good, more focal adhesion in these cells, but we could not reach. There was a suspicion that is good, but was not really reached at the moment. And then this is what was more impressive for me, and this is called the wound healing assay. It's simple to understand for an orthopedic mind as mine. It means that you create a scratch in the culture and you check how long does it take for the cells to fulfill the scratch. And you see that when you use the MD tissue collagen, the cells in 24 hours fill the gap. And this is not happening with the control. So we had very good answers to our question, because we have an augmented cell proliferation, more collagen, less collagen degradation, an augmented cell migration, and so on. We also published all these results. It was not easy to publish on the Cells journal. And we had the rationale for the use of this device in the clinical settings. And we started to use widely, I would say, in the Greater Trochanter Pain Syndrome. How do we do? Simple. We create a sterile field. We use the ultrasound to guide the needle where we want. And we want this material very near the tenocyte, because we have proven that is very good for the tenocyte behavior and metabolisms. And it's just an example I want to share with you, because before to finish my presentation. And she's a female of 74 years old with a left lateral hip pain, a worse pain day and night, because one of the bad things of the Greater Trochanter Pain Syndrome is that the pain is mainly at night during the rest. And you can see on the left hip a lot of white. It means that inflammation around the trochanteric area. And we are in October 2018. And this is an axial view of the same MRI. And this is 1 year later, after she did a 3-shot of Guna. Then she went to US because their family is there. Her family is there. And you can see in this slide, on the left in 2018 and on the right in 2019. And she improved a lot, even clinically. So she's very happy. And today we are using Guna as a first step in our Greater Trochanter Pain Syndrome. So thank you very much for your attention.